Funding for This Is Nashville comes from you, our listeners, and Music City Prep Clinic, Nashville-based provider for PrEP, and offering comprehensive sexual health services in an environment designed to be safe, professional, and shame-free. Learn more at musiccityprep.org.
I'm Khalil Ekalona, and this is Nashville. Welcome to part 4 of our housing series, In My Place. In My Place educates listeners on what cities like Nashville can do to prevent and end homelessness while caring for our neighbors who are still unhoused. Throughout the series, we talk to national and local guests about everything from best practices to worst failures and hear from people who intimately know the complexities of having nowhere to go. We want to highlight how affordable housing affects each of us, even if we don't think about it. So, this series was created in part and thanks to support from Pinnacle Financial Partners. Now, today we're focusing on housing and healthcare. Some would say housing is healthcare. This becomes especially apparent when we examine what happens to people's health and healthcare once they lose their housing. So, what do we know about the correlation between housing and healthcare? To help us gain more insight, I'd like to introduce my first guest. Bobby Watts is the CEO of the National Healthcare for the Homeless Council. Bobby, thanks for being with us. Welcome to This is Nashville.
Thank you so much. It's a real honor to be here.
Happy to have you here with us. So can you tell us more about the National Healthcare for Homelessness Council?
Yes, I like to begin, and my staff is probably laughing as you're listening, with reciting our mission statement, which is that grounded in human rights and social justice, the National Healthcare for the Homeless Council's mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. And we start that way because we want to stay right off the bat that we believe that healthcare and housing are human rights, and working to secure those rights for everyone in this country is a matter of social justice. And we support all of the federally qualified health centers around the country, but especially those 300 that have a special funding and emphasis on providing health care to people without homes. And we also support the approximately 150 medical respite programs around the country. So all that's on paper, but what really is the secret sauce of the council is that we are a loving, supportive community where the council is the vessel that shortens the learning curve for everyone. We bring people together to learn what works and what's as important, what doesn't work, so that we are all doing this better, serving the most vulnerable population.
You have experience in this work in other cities, New York City. You've even worked nationally on this. How does Nashville compare? Where do we stack up?
Nashville has a lot of things going for it. It's because it's a relatively small size compared to like New York City, where I'm from, but still large enough that it can have enough resources. I think Nashville, in my 7 years here, has made significant progress with moving forward on a number of things. Really want to commend one of your guests, Neighborhood Health. Their CEO, Brian Hale, has been really at the forefront of addressing homelessness from a healthcare perspective here in Nashville. So there are things that Nashville isn't doing as well as other cities, but some things that it's doing well. One of the things is it's a good size where people know each other, so it's easy to make connections and to work on things collaboratively, which I see happening more and more. Where
are we lagging?
I think there has been certainly movement, and this was in one of your earlier episodes in this podcast, in the series, in adopting housing first, though I think there is far to go. I think there's still much more to go in adopting that citywide.
Okay. Now, many of us are often not even aware of the dire health aspects for people who are facing housing insecurity or homelessness. What are some of the most prevalent health consequences that affect our unhoused population?
I'm really glad that you're addressing this, because most people, when they think of the catastrophe that homelessness is, don't always think about the health implications. And really, healthcare or health and homelessness are really intricately connected. Many people lose their housing because they are in poor health, and many people, once they lose their housing, their health declines. So really, for every condition, you will find that at elevated rates among people experiencing homelessness. And every condition is harder to treat as a clinician when someone is unhoused versus stably housed. So just really quickly, people experiencing homelessness are twice as likely as not being able to get medical care, not being able to get their prescriptions, of being in more pain. 6 times more likely to say, I don't feel confident managing my hypertension. And how can they if they don't have a means to measure their blood pressure every day, or even to store their medicines to make sure that it's not going to get lost or stolen. So health status and homelessness go hand in hand. I should say poor health status and homelessness go hand in hand, unfortunately.
What's led to this health disparity between unhoused and housed populations?
Well, we understand in healthcare now that what are called the social determinants of health make up 80% of someone's health status. So, and the actual health care you get only accounts for maybe 20%. So one of the largest social determinants of health is housing. If you don't have housing, if you don't have stable housing, you are exposed to the elements. If you are unsheltered, you're not going to be able to get a good night's sleep. You're not going to be able to follow up with your medical appointments. It just is a cascading effect.
How do issues like gender and race kind of impact the situation?
You cannot look at who experiences homelessness or the composition of homelessness in this country without looking at race and racism. African Americans make up 13% of the population, but about 40% of people experiencing homelessness. We see that roughly same 3-to-1, perhaps larger disparity among Native Americans. So it's not by accident. It's not just coincidence that the populations that have had their land stolen from them and their labor stolen from them are those that are among the most impoverished in our society, and that manifested in the most extreme form of poverty in this country, which is homelessness. So we also see disparities among housed people, among people who are among racial minorities. So when you compound them together, it really is an impact on the likelihood that someone's going to get good health care or be in good health once they are experiencing homelessness.
What about gender? We've done a couple episodes where we talk specifically about the trans community and how difficult it is for them not only to find help in securing housing, but help in securing adequate health care.
That is one of the shames of our healthcare system, in that people who are gender minorities, LGBTQ, transgender, do not have access to the same kind of specialized healthcare system, healthcare that they need. And often they will feel, because it's real, they will experience stigma and shame from mainstream healthcare providers. And we will see these gender minorities vastly overrepresented among people experiencing homelessness, especially among youth and especially among the transgender population.
You know, sometimes with unhoused populations, when you're talking to people who have housing, it's a little bit out of sight, out of mind. If they don't see it, they don't really recognize it going on, particularly in their neighborhoods, and they have their preconceived notions or opinions on it. Tell me, what are some of the biggest misconceptions you hear when it comes to health, mental health, and homelessness?
Well, one of the biggest misconceptions I hear about homelessness is that people choose to be homeless, that this is a choice. Someone is experiencing homelessness because they have no other choice that they feel is viable for them. And another misconception is that everyone who is experiencing homelessness, it's because they have mental illness or substance use disorder. That is not true. It is true that people experiencing homelessness suffer from mental health disorders and substance use disorders at higher rates, but it is not the majority of those experiencing homelessness. Survey after survey says that. Among certain subpopulations, it might be, but among homeless people experiencing homelessness in general, it isn't.
Now, you're an outspoken advocate who participates in local and national homeless memorials. In fact, most recently, you were a part of a rally before the U.S. Supreme Court about a case that could further criminalize homelessness. Let's listen to a clip.
But this law does nothing to solve homelessness and doesn't even make a pretense of trying to help the individual. It only seeks to find them, punish them, and move them from one spot to another. It is guaranteed to make suffering and homelessness worse. The solution to unsheltered homelessness is housing, health care, and supportive services. We know they work.
Tell us about that case and its potential impact.
Yes. So the case is Johnson versus Grants Pass, where Grants Pass is a city in Oregon that passed law that says if you are unsheltered, if experiencing homelessness in their city, if you sleep, if you lie down, you will be fined. And if you can't pay that fine, then you will be jailed. And that is the case going before the Supreme Court. Previous courts have found that it violates the Eighth Amendment against cruel and unusual punishment to punish someone for merely existing in public when they have no other place. So that is the case. We are really hoping that the Supreme Court will not overturn the lower court's findings that to punish people, fine them, arrest them for existing is unconstitutional.
This really feels like a moral issue. Like we understand the institutional and structural impacts that cause homelessness. But what about the moral causes?
It is a moral crisis. I say it's a public health crisis, and it is a moral crisis. We are the most powerful country in the world. We are among the richest countries in the world. And we can provide housing for everyone, just as we can provide public education for everyone. But we as a nation have chosen not to. And this is a relatively recent thing. I'm kind of old, but I'm not that old.
Okay.
But I remember when we didn't have mass homelessness like this. And I grew up in a poor neighborhood in Brooklyn where a lot of people were poor, but we didn't have people sleeping in the subways and so forth. Mm-hmm. When I go to that neighborhood now to go to visit, it is gentrified, but you have people sleeping in the subways at the very stop. So as a nation, we have said we're not going to fund housing to make it affordable for poor people. And we actually, from the 1970s till now, we have reduced our commitment, our funding in real terms, by over 75%. And there's no accident right when that funding stopped or when it greatly declined that we have begun to see an upsurge in homelessness in the early 80s. So it's a man-made problem through our policies, and we can change it. And the failure to do that shows who we are as a nation.
You know, I'm interested because it is the policies that we can change. It's the policies that have enacted and put us in this situation. But those are merely just the politicians, the people we elect to office. Really is a reflection on us as citizens, would you say?
I absolutely agree.
Now, you know, I'm interested about the role that the healthcare industry has in helping to solve homelessness. Can you tell me a little bit more about that?
Yes. So, you know, I'm really fortunate being at the National Healthcare for the Homeless Council and seeing what healthcare for the homeless programs and medical respite programs are doing around the country. And their expertise is unparalleled. And what they're doing is just really tremendous. So what healthcare for the homeless providers are doing and healthcare providers are doing is they are treating the underlying problems that have caused many people to experience homelessness, or without treating them, we know that they will not be able to escape homelessness. So previous on this series talked about the importance of housing first and providing that supportive services to people once they become housed. And healthcare is a crucial part of that, especially if someone is suffering from mental illness or from substance use disorder. These are medical problems. And healthcare providers are providing services, treatment, and we have so many more effective treatments for both of those groups of conditions than we had 20, 30 years ago, that it is really making a tremendous difference.
What can be done to improve the connections between healthcare providers and people who are looking to help solve homelessness?
Well, I think one of the things that is really important, and one of the things we're working on as a council, we would like to see happen more, is at the local continuum of care to really bring more healthcare providers around the table when we are assessing the vulnerability of of individuals to make sure that we are really doing a better job than we are currently doing, and this is around the country, of assessing their healthcare status, making sure that's being taken into account when we say what kind of placement that they need, what is the priority. And one of the things I'm excited about, in some communities, we're seeing medical respite programs being incorporated into the continuum of care. So if someone needs medical respite as a next step to recover, that becomes part of the bridge to housing.
We're about to take a break, and we're going to talk about medical respite when we come back. But I do want to close with this, seeing that, we know what the politicians can do. I think, what do you want to say as someone who studied this and worked in this field for a long time in different parts of the country? What do you want to say to the listener, someone who's listening, about not only what they can do, but what they should keep in mind as we go further, seeing that this problem is getting worse at an exponential rate?
Yeah. I really want people to think, how would they like to be treated? What would they want society's policies to be? What would they want their neighbors' response to be, their church's response to be, if they or their child or their brother or sister was the one on the street? And then I think if we treated others the way that we wanted to be treated, if we loved our neighbors as ourselves, that's something we can do on a local level, on an individual level. And I think that would also lead to changes in policies if we take that to the next step.
Bobby Watts is the CEO of the National Healthcare for the Homeless Council. Bobby, thank you so much for being with us today.
Thank you so much.
We're going to take a short break. When we return, we'll talk with a panel of folks who represent Nashville's nonprofit and government sectors to learn more about the healthcare services available to unhoused people in our communities. We'll be right back. This is Nashville.
Funding for This is Nashville comes from you, our listeners, and Music City Prep Clinic, Nashville-based provider for PrEP and offering comprehensive sexual health services in an environment designed to be safe, professional, and shame-free. Learn more at musiccityprep.org.
I'm Khalil Colonna, and this is Nashville. When's the last time you've been sick? Recovering from something relatively minor, like a sinus infection or one of the growing number of respiratory viruses that we've got going around, or something not so minor. Are you a cancer survivor, amputee? Have you had a colostomy or catheter? Now, some sort of physical hurdle is pretty much non-negotiable for us if we live long enough. What are some of the things that got you through when you were healing? Was it family, a flexible job, ability to quickly get back and forth to doctors? What about your warm bed? How about your health insurance? Well, folks living in Nashville without a home also have to go through and get through major health crises, often without all of that. Hospitals often discharge people straight to the streets, and shelters, they're just not equipped to accommodate these needs. This means unhoused people often recover in much less than ideal environments like tents, cars, and temporary beds. We've got a sore lack of respite care in Nashville. There are, though, a few nonprofits creating space for physical healing. This is Nashville managing editor Tasha A.F. Lemley talked with two men who found space to heal at the Village at Glencliff.
Old and broken down. How you doing, Sonny?
I'm good. How about you?
All right.
The Village at Glencliff is tucked away in a wooded neighborhood in something of a Big Dipper of three major interstates. It's really peaceful in this large church parking lot that now houses 12 tiny homes. It's a place where unhoused people can stay housed while they heal from illnesses and injury.
I was doing too much work and got a hernia. And I lost my place because couldn't pay rent. Couldn't work, couldn't pay this or that.
That's Bascom Lane. He's been living here for a couple months now, healing from his hernia surgery through their medical respite program.
You're vulnerable on the streets anyhow, but when you have a surgery, then you're down. So you're easy pickings. So you get a chance to relax here. And, just for today, I don't have to worry about people. Just for today, I'm safe. And then you can focus on your physical recovery.
And the tiny homes are lovely. They're small, but there's pretty much all the parts of a studio apartment.
You have your bed, your nice bathroom, your refrigerator.
It's a little kitchenette kind of thing in there. Sink, clothing rack, a bunk, or a workstation, kind of like a desk. So it's like a one-room efficiency. Easy to keep clean because it's small. My name is Ewing Jones. I was living in my truck, SUV, which I had been living in off and on for about 10 years, since I was 58, under the Jefferson Street Bridge. I was diagnosed with colon cancer. Early stages, I got lucky, but I had to have the surgery and they cut out part of my colon. And quite frankly, I'm not looking forward to trying to sleep in a car, trying to recover from surgery. Actually, the recovery stuff didn't even dawn on me. All I was worried about was the surgery.
Ewing, who goes by E.T., says normally while living in the truck, if he got sick or the weather turned really bad, he'd stay with family for a night or two. But this kind of recovery time, he says it was too much to ask for. One family member was already taking care of a sick parent, and another was receiving government assistance.
Me being on her lease would have given her whole loads of trouble on Section 8. So it wasn't like there were people that were willing to help. It's that programs and systems and circumstances prevented me from accepting the help that was offered from them because it would put them in a bad situation. And I'm not trying to make my burden somebody else's burden. I'll carry my own load as much as I'm able.
And so E.T. had an outreach worker who hooked him up with one of the tiny homes at the village. He spent a year there, first recovering from the colon cancer and then a spinal injury from a fall. And now he's been in his own apartment 2 years. Part of their work at the village is to apply for and secure permanent housing for everyone living there. So when they're all healed up, it's not a guess where they're going.
When you're living from day to day, there isn't a whole lot of long-term planning. It's pretty much, what do I have to do at this moment to get through this moment?
For now, there may only be a dozen or so beds in the Village at Glencliff community. Still, even though they're small, they're one of the best things Nashville has going for it when it comes to providing respite care for people with nowhere else to go.
Now, before the break, we heard from Bobby Watts, CEO of the National Healthcare for the Homeless Council. Now we're shifting to a panel of experts representing Nashville's nonprofit and government centers. First up, we have Julia Sutherland. She is executive director of the Village at Glencliff.
Hi, Khalil.
Hi, Julia. Thanks for being here.
Oh, thanks for having me. This is great.
I really appreciate you being here. Okay, so we just heard a couple residents at the Village at Glencliff. Tell us about the services you all provide and the gaps that your program fills.
Sure. I think gap is a really good word because it can be really big. I think the general public expect hospitals to lift more than they're really equipped to. And it's an incredible burden on the hospitals. They patch people up really well. We have wonderful hospitals here in Nashville. But when it comes to the complexities and the patient-specific requirements to gain housing and medical and social benefits, that's just too complex to expect hospitals to do that for everyone. And as Bobby said, we have quite a few people coming into the ER who are experiencing homelessness. On average, people experiencing homelessness visit the ER 5 times a year. And that can equate from $18,000 to over $100,000 for a hospital. That doesn't even include the community costs like police or emergency services. So when we work with hospitals to have patients discharged to the Village at Glencliff, we're breaking this cycle of poverty, of ER to street to shelter to jail to ER and back. And so we're looking at shifting resources to more sustainable allocations. And so the gaps we're filling are what you were talking about earlier. When someone who's housed gets discharged from the hospital, you go home, you have a social network of people. Somebody might bring you a casserole, check in on you. When you're unhoused, not only do you not have the social network, you don't have a safe place to sleep. So you're constantly on alert, and that keeps your body from healing, and you're incredibly vulnerable. So we designed the village. Centric Architecture did an amazing job, given the brief. And this is one way that we're different from other medical respite communities. We have 12 tiny homes, which really gives people that privacy that does not exist when you're living on the street. Private shower, private toilet. We don't think about these things when we're housed, but yet they're incredibly important to healing. And so on top of that, we navigate people's medical care. So, when you've been living on the street, you don't own a laptop, healthcare is completely digital now. So to access your records, schedule appointments, renew your prescriptions, even all of that is online. So we just recently got a grant from the state of Tennessee, ECD, to help educate people regarding digital literacy. So that opens up telehealth to them. It opens up accessing their records and navigating on their own. So that plus the housing navigation, when we're looking at somewhere between 2,000 and 10,000 folks in Nashville experiencing homelessness, that's a really long list of folks waiting to get into housing. And if you don't have help navigating that, just forget it. It's too tough. And the last thing is the social benefits. So we take all of that off the hospitals and help walk people through those processes.
So let's talk a little bit about the different types of medical respite. The Village at Glencliff does not, you don't release people back into homelessness. Unlike most respite programs nationally, what are the difficulties your model faces considering the current affordable housing crisis that we have here?
Right. Well, the top difficulty is funding. We get our funding through hospital contracts, through individual donations, grants, different contracts through government agencies, and that falls short of what we need to do. We really firmly believe, and the data, the limited data we've collected through the number of people that we've housed over the past 3 years shows without a doubt that if you keep people housed, don't put them back on the street, don't let that gap, as you were saying, come back, the chances of them staying in housing escalates. We definitely are seeing a reduction in recidivism, so people not going back to the ER. We have, I would say, I think we determined 53% of the folks that come to the village never go back to the hospital for an unscheduled visit because we connect them to a PCP and we help them plan their medical care rather than waiting for it to be an emergency, rather than letting chronic illnesses go on. So funding is a big deal. The other thing that we have somewhat solved for is mental health therapy. And it's critical because it's hard enough. People who have had surgery, you come out of a hospital and you might have some mental health issues because it's a traumatic thing. Well, add to that living on the street and you have some serious trauma to deal with. So we've found that it takes a long time to get into mental health therapy because the system is overwhelmed. We have engaged a part-time mental health therapist who is on campus. Our residents get to know her, and this has been a real game changer. A lot of folks have a stigma about getting mental health care. They don't want to be labeled. They don't want to have that follow them around. It makes them feel even more vulnerable. So if you can talk to somebody you know and start dealing with that, we see an increase in people being able to adapt more independent living skills and move into housing more quickly.
Now, Shauna Tucker is Interim Chief Operating Officer at Neighborhood Health. She's also with us today. Shauna, your organization has become one of the main providers for people experiencing homelessness. Tell us about the programs that Neighborhood Health offers.
Yes, thank you so much for having me today. Love being here with you, Julia, doing really amazing things. So Neighborhood Health, we have 11 clinics, mainly in Davidson County, and we serve birth to end of life for all of our patients, everyone in the community, and that includes our unhoused neighbors. So they come to our clinics, and when they can't come to our clinics, we go to them through our street medicine team, which is a phenomenal group of healthcare providers and enabling service people they're helping to connect need and resource that they identify in the community. We have a number of different programs in the community and in our clinics that we're able to link people up with. And if we aren't able to provide it ourselves, then we aren't, shy about asking for help with our community partners. Specifically for our unhoused folks, our street medicine team saw over 3,000 people, that were unhoused in 2023, and our organization as a whole saw folks that identified as unhoused, about over 18,000, I think, collectively across the organization.
Last year, 18,000 people.
Yeah, 18,000 encounters. So there could have been a couple of duplicate people in there.
Okay.
But yeah, 3,000 visits for a mobilized team that includes a medical provider, a registered nurse, a driver, and then a patient navigator role. That individual is kind of like mobilized wraparound service detective, looking for what they can do. But it's difficult with the climate around homeless encampments in Nashville. We do have to sort of follow the people. They get displaced, as we've talked about, criminalized. And so that was a really devastating blow to being able to support those folks. As Julia mentioned, this vulnerable population needs to be accessible to get the health care that they need. They need the supportive services to be able to meet basic needs and even have a chance at coming out of homelessness. I think we can all agree that when you're struggling to meet basic needs, it's really difficult to struggle to do anything but survive. Mm-hmm. You're not struggling to grow at that point. So I could probably go on all day. There's a lot of community services that we tap into. I'm
really curious about what it looks like to be in the field for neighborhood health. Like you mentioned how hard it is to follow up with patients. The weather's getting warmer now. Is it different now at this time, late spring, as it is potentially in December in the middle of winter?
Absolutely. Our team is boots on the ground, quite literally climbing to get to our patients in some situations. The weather plays a huge role. We try to get weather-ready equipment into the hands of people that we're serving, tents and sleeping bags that are appropriate for the temperatures that are coming up. We definitely try to get folks to cold and warm weather shelters when those open up. And, but our services don't stop. Regardless of the weather, the encampment team is going out the street medicine team is going out to encampments and to some of our community partners. We have scheduled visits Monday through Friday with Community Care Fellowship, Loaves and Fishes, and then, going to those encampments as we identify them. That doesn't stop. Mm. Yeah.
Now, with encampments, how difficult is it to keep track of them? We've got state laws that have made encampments illegal, and also law enforcement will move encampments around.
That's right.
I'm sure that adds to the difficulty in keeping track of people, but how do you all just kind of navigate through that with the encampments constantly changing, let alone the people who stay there?
Well, you're right about that. It's such a controversial and complex situation that we have going on here, and it's really sad. So our team is the only way that we're able to effectively support and provide care to our patients that are unhoused and outside is through developing trust in many situations. And so that trust that our street medicine team has with the community, with the unhoused community, allows us to stay in communication about where encampments are going to travel to next when they're displaced. But that trust also means that we take it very seriously, and we are very private about where we are serving our patients.
Now, let's welcome Deanna Allen-Robb, Assistant Bureau Director of Population Health with Metro Public Health Department. Welcome to the show.
Hey, thank you for having me.
Thank you for being here. Okay, so Deanna, from a government perspective, where do you see opportunities for health, housing, and homelessness sectors to collaborate more?
Yeah, thank you for that question. First, if I may preface my response to say that a part of our role at the Public Health Department, I like to say, is making the invisible visible. We do that through the data that we collect and how we're sharing what we're seeing at a population health level back to the public. One of those aspects that we see that is particularly troubling or concerning is that we're responsible for reviewing the deaths of all Davidson County residents under the age of 18. That happens through our child fatality review. And when we are looking at deaths, particularly of babies, about 25% of the babies, children under the age of 1 that are dying in Nashville are dying from a preventable death that's associated with housing overcrowding. We have focused on individuals literally living outdoors or in shelters or in a place not meant for human habitation, but there's a whole population of children and families that you don't necessarily see in that homelessness environment right now, but are still experiencing devastating loss because the best that we can do is live in overcrowded conditions. So with regard to those opportunities for collaboration between housing, healthcare, and government, I would lean on an example from an insurance company, United Healthcare, the largest health insurance company, medical provider in the United States, has invested, I think, in the tune of somewhere around $1 billion already in developing affordable housing in communities across the United States. I think that's an excellent example of our healthcare industry recognizing the impact of housing. Would you rather pay, $100,000 for somebody's healthcare, or would you pay, $20,000, $30,000, $40,000 to help house them? An insurance company, their investment obviously is going to be in what helps to drive down costs, but also ultimately what helps to keep people healthier in the long run.
If you're just tuning in, this is Nashville, and I'm your host, Khalil Ekalona. We're talking this hour about healthcare and homelessness in part 4 of our housing series, In My Place, brought to you in part by Pinnacle Financial Partners. My guests are Julia Sutherland, Shauna Tucker, and Deanna Allen Robb. Now, Deanna, we're thinking about homelessness. We think about the shelters on the streets, but you mentioned this. I want you to go a little bit deeper into it. Families living in one apartment or a very, very crowded space. How bad of a problem is that here in Nashville?
Yeah. We have home visiting services that we deploy through the health department, and a lot of other agencies do as well. Neighborhood Health is one that has home visiting services. These services are provided to people who are pregnant or who just recently had a baby, and typically you're following a family until the infant is 18 months of age, or up to 2 years, and sometimes up to 5 years, depending on what their needs are. When we started looking at data just among our internal home visiting programs that the health department deploys, about 80% of our home visiting families were living in overcrowded conditions. We define that really as, do you have more than one family living in a one-bedroom apartment? Is there enough space for every person, particularly an infant, to have a safe place to sleep? And a lot of times there's just simply not room to put a crib, a pack and play, or even a box in some cases for a baby to sleep.
I really want to talk about how we can best approach this issue. So many people in need. Some would advocate for standardized practice to kind of help quickly process as many people as possible, but every human situation is different. How can we achieve the goal of securing housing for people while paying close attention to their personal needs to ensure a successful transition? I'd love to hear from all of you on that. Julia, you first.
Well, top of my wish list would be Medicaid expansion. As far as we're concerned, that not only opens up better healthcare opportunities for people, but I won't go into the details. It opens up more housing opportunities for people. And I know it's a political issue. There is something, I don't know how long it will take our legislature to adopt that, but you can adopt a Medicaid 1115 waiver without having Medicaid expansion. That would also offer broad coverage and tremendously help our agencies house people faster.
Shauna?
Well, I can't say that I don't agree with 100% of what Julia is sharing. Beyond that, I think as a community, we have to collaborate in a little bit more of a streamlined way. tap into those resources as a whole, have more conversations with the public about, sort of demystifying the stigma of homelessness, and that it is not, criminality. It's not always mental illness. It's not always one thing, like you mentioned. Every unique situation, it needs a unique approach. So I think we need to come together as a community a little bit better around that.
Deanna.
Sure. I would say larger footprint housing, so developers that are willing to build larger footprint houses to house families in particular. You can't put a family in a studio or an efficiency like you can a single individual. I will also say individuals who live in Davidson County that are landowners, if you have a spouse and you all got married and you combine property and you have a townhouse that you're renting, consider joining the Metro Low Barrier Housing Collective to make that housing available to individuals, and keep applying pressure. Any one of us is a paycheck or a natural disaster away from experiencing housing insecurity.
So let me ask you this. We got about 30 seconds left. What are some local opportunities we have outside of that brilliant idea for homeowners and landowners to expand their properties?
Sure. It's coming. It's June. We have our Continuum of Care. This is our renewal project, a new project, funding, our HUD funding, our housing funding that's being made available as a part of our local competition. If you are a nonprofit organization, a healthcare provider, please join together, collaborate on how we might be able to provide both housing and healthcare as a part of one
Deanna Allen Robb is with Metro Public Health. She was joined by Julia Sutherland with the Village at Glencliff and Shauna Tucker with Neighborhood Health. Thanks to you all for being here. Really appreciate it.
Thank you.
Thank you
so much.
Okay, we're going to take one more break. When we come back, we'll get some feedback in real time from someone with lived experience. You can always join the conversation by tweeting us at This Is Nashville. We'll be right back. I'm Khalil Ekalona, and this is Nashville. We're ending our episode by bringing back a special guest, Deirdre Childress. Deirdre also has lived experience. We asked her to listen to today's episode and provide us with some live feedback by answering three questions. All right, so I want to break this down. But first, we're going to find out, okay, tell me, what was your experience with access to healthcare when you were struggling?
While I was struggling, I had TennCare. I finally did get approved for TennCare because I had small children. And I had TennCare, then I got Medicaid because I had some health issues. But until I found a job, once I got out of homelessness, once I got stable and got me a good job, I lost it all. Once I worked a job that made an equal amount of money, you just lose it. That's just what happens to us in this society. So even today, I can't afford health care because I make a good amount of money.
So you can no longer afford health care?
No.
Because you make too much money?
Right.
To qualify for any sort of assistance?
Yes.
Wow.
But if I go back to TennCare and housing, my quality of living won't be the same. So I choose to keep working and to not fall back into the system.
Are you worried that if a medical emergency emerges, that it's going to be tough to address it?
Well, I have had several medical emergencies where it hasn't been able to be addressed, and I just pray and keep going. So I've had local people help me with like medicine and different stuff, and a lot of places offer like cash payment. A lot of clinics I found downtown, easy clinics for my children. I've been able to get them the help that way, paying cash.
You're telling me this is your situation, but would you say that other folks are going through the same thing?
Most definitely. Like I can name at least 25 people that I know has risen above poverty, and they are really struggling with health needs.
So you listened to today's episode. What stood out to you from listening?
What stood out to me? First thing, housing is healthcare. I'm one of those people that believe that. I believe housing is safety, housing is healthcare. All of it should be in one. We should have free housing like we have free schooling, like you say. We should have free housing and free healthcare. In order to get healthcare, you should have equitable housing. In order to get housing, you should have good healthcare because it all comes in one. That was what stood out to me first. And then, of course, the health disparities, the moral crisis. We as a nation have chosen not to help our less fortunate individuals, and it's very sad. It shows us we are, as a nation, from 1970s to now, the HUD funding, the man said it, HUD funding is down more than 70%. That's ridiculous. You would think with how services have become innovative, how our people have risen above to work more, to help themselves to do more, you would think that number would be way lower. But that's kind of ridiculous, over 70%. And then I heard them talk about overcrowdedness of homes. I have seen that with my cases and my caseloads with my clients and stuff. It's 20 people living in a 2-bedroom. And what do you do when everybody done lost their way? So that's what stood out to me. I have another question, but I want to talk a little bit about the moral crisis, because it seems like we're in a society now, we have a good part of the population, not everyone, a good part of the population is really working hard, or they pride themselves on being aware. Not only aware of their own lives, what they call it, mindfulness, being aware of what's happening to other people. But here we see the homelessness issue, despite the wonderful people like yourself and the guests we've had on who are trying to do something about it, we're seeing it exacerbate into a worse and worse condition for people. What do we have to do to take kind of the moral and philosophical blinders off to actually do something about this problem? Great question. For me, I believe that we need to come together as local organizations, community partners, and civilians should create programming and even come together some type of way to create funding to help at a local level, because clearly the state and the federal level is not helping us or our people.
So the reliance on the government
is not
be
working.
As strong. They're not doing anything. We have to do something ourselves.
Today I'm making a stand. I'm going to go home, I'm going to pray, and I'm going to create a plan to help my people. And that's what my mind is on right now.
Okay. Now, let me ask you this. What would you like to hear more about in upcoming episodes? We've got 5 episodes left. What do you want to hear us talk about and cover?
I believe we should talk more about the overcrowdedness, and I believe these developers and these people that can help us create better, equitable housing, safe housing for everyone should consider it's not just 1 or 2 people that's unhoused, it's whole families, grandmothers, husbands, wives, children, it's just so many people that need to be housed together and not separately. So that's what I would like to hear more solutions on creating larger spaces.
What does this tell you about Nashville? You know, I moved to Nashville, and a lot of people say Nashville's a close community. People try to help each other out, which I have found to be true. But in my most recent travels, running into people, I mentioned that I was from Nashville, particularly American expats. And they said, hey, it's a great place to party. And I said, yeah, that's nice, but there's also a lot of issues. They didn't want to hear about that.
Exactly.
You know? What is it? What does Nashville have to do to kind of separate themselves from other places in the country, but to show that it actually cares the way the city claims to?
I believe we need to change a lot of stuff in the upper level. That's just me. But I think if we change our housing first model first, if we can get one that really helps our people to get more people housed, I believe that's where we should start.
How would you like them to see that change?
Create a system that's going to offer more resources and more equitable things to help people stay, what word am I trying to use? That help people to have gainful employment, like healthcare, good salary, stuff like that. If we have more resources, not just housing people, but bringing them in with wraparound services. That's what I'm trying to say. More housing with wraparound services. We could see a big difference. Oh, and we need to make people save. Right? We get these services and we get another chance, even myself, we get another chance to do better if we're not saving for a rainy day. We need to teach people that because something will happen.
I want to thank you so much. Deidre Childress has come on to offer us insight. Deidre, really appreciate it. Thanks. Good to see you again, too.
Great. Thank you.
All right. That is it for us. And thanks to you for tuning in this hour. This is Nashville is a production of Nashville Public Radio. Today's episode was produced by Judith Tackett and Tasha A.F. Lemley. It was directed by Tasha A.F. Lemley. Our technical director and board operator is Liv Lombardi. The theme music for In My Place is provided by Vein Melter. Now, special thanks to Pinnacle Financial Partners. We wouldn't be able to do this without them. Thank you very much. You can listen back at thisisnashville.org or wherever you get good podcasts. And the conversation doesn't end here. Tweet us at This Is Nashville. Find us on Instagram. Tell us what you want from our show by filling out our quick survey online. And another thing that we forgot to mention, there is a $1 match grant going on at the Village of Glencliff. It ends on July 1st. Go online to find out more about that. This is Nashville. I'm Khalil Ekalona. We'll see you tomorrow, everybody. And be good to each other.